We'll start with the Ask the Expert session with Dr. Warren Brenner from Boca, Raton, who's actually wearing his white coat because he's on call this weekend. So let's start, Warren, with the first questions. We have a lot of questions about COVID-19. The first question that came in was from Carol Tucker, who said that she had a specific question about the COVID-19 vaccine. She had a stem cell transplant in the middle of last year, middle of 2020. However, she was diagnosed with COVID in December of 2020, so 2020 last year. She received treatment with monoclonal antibody therapy and has actually done extremely well. And so her question now is, she is 3 months out, and she's asking, should she just go ahead and get the COVID vaccine now, or maybe she should wait until 6 months out? So what do you think, Warren, about the timing of vaccination?
Thank you for inviting me, Brian. So thanks for that question, Carol. I think that's an important question that we're dealing with a lot these days. So our general recommendation would be to go ahead and be vaccinated roughly 3 months after you were infected, as long as there's no contraindication to you getting the vaccine. I presume you may be on some maintenance therapy, and if you're on something such as lenalidomide, that's not a contraindication to getting the vaccine. From a timing perspective, if you did it on your week of therapy, that would be very reasonable. But there doesn't look like there's any issue for patients on maintenance therapy getting the vaccine. So we would recommend that you go ahead and get that vaccine roughly 3 months from the time of your infection.
The earlier questions. Thank you so much, Warren. And so I'm trying to scroll down to the, here we go, to the earlier questions. Amira's going to do that for me. But one other question, just linked to what you were just saying, Warren. A patient was asking if they're on revlimid maintenance, is it okay to get the vaccine? And asking actually if it would be good to get it on the week off of the maintenance. So how are you handling the vaccination during the maintenance?
If patients on lenalidomide maintenance without dexamethasone, we would go ahead and recommend getting the vaccination. It could be done on the week off, but I don't think we have any specific evidence that it would be wrong to get it well on lenalidomide. But I think it makes sense to get it on the week off, and then when you're due to have your second vaccination, if you're getting the 2-shot vaccination from either Pfizer or the other company, then I think trying to time it on your week off would make sense. But I don't think we have any specific data that it would be wrong to get it while you're still on lenalidomide maintenance, as long as there's no evidence of neutropenia.
Absolutely, absolutely. I think that I know it's very, very frustrating for patients because right now we actually just don't have any data. And so I use the formula of common sense. You know, if right. You can take the vaccine when you're on your week off, that's probably a better idea. Yes, and also that applies to other therapies. I mean, it's probably not good to take a dose of Darzalex, for example, on the same day as the vaccination. So just using some good common sense about the timing of the vaccine. We have another question, which is actually a common question. A patient wants to know, after having had the second dose of the Pfizer vaccine, her doctor has recommended that the antibody response be checked 1 to 2 weeks later. But this patient had learned that apparently at Johns Hopkins, they're recommending to do it 4 weeks after vaccination. Frankly, I don't think that we are routinely checking the antibody levels, so we're not entirely sure how to interpret them. But how are you handling questions related to the antibody testing, Warren?
Our recommendations right now are not to have the testing done. We're not sure how it potentially impacts on what we advise patients. I think if patients do end up having a high titer antibody response, we would still recommend that they follow CDC guidelines as far as social distancing and wearing masks when they're exposed in public areas. And the same thing for patients who may not mount an adequate antibody response. First of all, we're not sure what is an adequate antibody response. And we really don't have any literature about what titer would be protective versus non-protective. So I think it just ends up sometimes creating confusion and sometimes creates other additional problems and questions. So our general recommendation has been not to test patients, but I'd be interested to see what some of the other panelists think.
Right. I actually agree with you, Warren. I mean, I think that we do need to learn, and if there's a study going on at Hopkins, for example, perhaps that can be helpful for all of us, but it can be confusing in the short term if we don't know how to interpret the information. Yes, so I'm just looking at some other questions that we have here. I'll just switch to something completely different. Oh, no, if you go back up toward the top. Yeah, so just this is something that we'll touch on later, but I'd be interested in the status in Florida, Warren. So this questioner, switching away from COVID, is asking, has Glen Rep been widely accepted? And so obviously, belantamab was approved a little bit ago. Has it been possible to get that rolled out in the different groups in Boca and in Florida? How's that been working, would you say?
Yes, thank you for that question. So, Glen Rep certainly is a useful drug in our armamentarium for patients with heavily pretreated myeloma. Once signing up for the REMS program as a physician, which is a fairly smooth process, I think the hardest thing for us in the community has been having an ophthalmologist ready available, as when we do administer this drug, patients need ophthalmology exams prior to each dose, prior to starting therapy, and then prior to each dose, at least 1 week after their last dose and prior to their next dose, they need a good eye exam to evaluate for keratopathy that may be evolving. So we do have access to the drug. We are using it. Is sometimes a little bit of a difficult process getting the right ophthalmologist who understands the side effect of this drug, how to grade it, so we have appropriate criteria for dose adjustment if needed. But it is currently available and being used.
Yes. That's great. I think it's been rolling out at different speeds across the country related to the coding for the reimbursement, actually, plus getting all set up for the eye exams. But this is helpful information for Rafat and Paul as they're talking about the relapse options a little bit later in the morning. Another question about treatment: can Kyprolis be used with Pomalyst and Dex with the Kyprolis once a week? Have you been using this combination locally in Florida?
We have used that combination. We know there's not always going to be phase 3 data for every combination in myeloma, but there is data with that combination. It's been effective. It's been well tolerated. Although I'm not using that particular combination very commonly due to Pomalyst or Kyprolis often now being used together with the CD38 monoclonal antibody.
Right. I'm just scrolling through some of the questions here. Another one, I'm on maintenance with Velcade every 2 weeks. Is it safe to get together with friends who are vaccinated? I'm also vaccinated.
Again, I think that's a tough one because we don't know in patients with hematological cancers such as myeloma exactly how protected they are from these vaccinations. We hope there's enough adequate protection to prevent serious illness. So my recommendation has still been to my patients with myeloma, even if they've been vaccinated and friends have been vaccinated, to follow the CDC guidelines as far as social distancing and mask wearing, at least until we can see much lower numbers of COVID in the community.
Yeah, I actually fully agree. I think I strongly recommend protective measures, even combined with vaccination, especially with the new variants circulating in the community, and if the community level is still relatively high. So I think that wearing a mask is, and we'll talk about this a little bit more later. Yeah. Another question here, how well does the COVID-19 vaccine work if you have MGUS? I don't know if you have any particular perspective on that, Warren.
Again, I presume there were some patients who may have had undiagnosed MGUS on these vaccine trials. And unless there's hypogammaglobulinemia as part of the MGUS, I think hopefully patients with MGUS should mount reasonable responses, but again, I'm not aware of any particular literature.
Right. The only data that's come out related to MGUS has actually been that patients with MGUS who have developed COVID-19 infection, and that's been a relatively small number, have actually done equally well versus what you call normal people without any type of cancer. They've done much better than patients with myeloma, for example, and the outcome has been linked more related to age or any other medical problems that they might have had. Yes, so I'm just looking to see what else we have here. Yes, diagnosed people. A lot of questions about starting to attend indoor dinners with people who are unvaccinated. We really touched on that. I think that Warren, it seems like both of us would recommend continued caution when you're getting together with people.
Right.
Question about an outdoor wedding with a large crowd. Yes, I think we're talking mostly about common sense here. You know, just be cautious and paying attention to the people around you.
Right.
Thank you so much. Can a relapsed patient on active therapy with Dara Landex receive the vaccine? Yeah, so it's just another question related to therapy and getting the vaccine. I think we've mostly answered that. Just to maybe pick a point during the cycle when perhaps off of the lenalidomide and not the same day as the daratumumab. Yeah.
Right, and if patients are in a good remission, it would be very reasonable to just delay the next cycle for a short time period. So there's a little bit of a break between the therapy and the vaccination just to hopefully increase the chance of having a good immune response. So in my patients who are stable with good control of their disease, I may delay their therapy by a few weeks so they can get their vaccines.
Right. Another just related type of thing. How long after bone marrow transplant should you get the vaccine? Yeah. And we touched on that a little bit earlier. Yeah.
Yeah, I think the general recommendation is probably waiting at least 3 months, if not 6.
Right, exactly.
We got the vaccine.
And then there's a question here, actually, I'd be interested. Is a spike in light chains a common reaction to having the COVID vaccine? This has come up a little bit. Questions have come to me. Have you seen any change in myeloma protein levels that you might link to the vaccination? I haven't heard of that, actually, but have you seen any of that?
No, not particularly aware of seeing that. We definitely do see patients develop some local lymphadenopathy sometimes. So from an imaging perspective, if patients are getting PET scans, we're trying to not do the PET scans too close to vaccination, just because of some false positive findings on a PET related to vaccine use. But I'm not aware of any change in myeloma numbers or light chains following vaccination.
Brian,
yes. Yeah,
if you don't mind.
So, yes,
yeah, my
course.
experience is that you will get a transient rise in kappa light chain after the vaccination, especially after the second dose, but then it'll normalize a month later.
Okay, that's good to know. Now you specify kappa.
Yeah, I don't know why it's more common. I mean, I haven't seen the M protein go up, or the lambda light chain go up, but for some reason, we see transient rise in the kappa light chain.
Hmm.
Couple of weeks after the second vaccination, usually.
Right. Okay. Then actually, we're going to be talking about this shortly. A different question is standard of care induction therapy moving to quad therapy with DARA. So where does that stand, do you think, Warren? Are you using 4 drugs incorporating DARA up front in some initial therapy patients or not yet?
Yeah, great question. So I think that is something that's a hot debate right now until we have data from the ongoing phase 3 trials. We know based on the Griffin trial, randomized phase 2 trial showing the benefit of the addition to daratumumab to RVD induction. So I discussed it with patients, and there are some patients who I am using quad therapy. I'm a believer in giving our best drugs up front and not saving them for later on. So I've kind of switched a fair amount to RVD DARA as my go-to regimen for patients with myeloma, regardless of whether they have standard or high risk.
Yeah, interesting. Yeah, so there definitely has been some movement in that direction. And we'll talk about that more later. We'll get the perspective from our other experts on the line here. Yes, let's see if we have any others. A lot of questions still about the COVID vaccine. Yes. But we've really covered it. And you touched on it. A patient is concerned if the neutrophils are low on lenalidomide about getting vaccinated. Yeah, I mean, I think that if your blood counts are low, it might be good to have a rest period and have your blood counts recover before getting vaccinated. And Warren, you touched on that a little bit earlier.
Right.
Yeah.
We would delay vaccination while someone was neutropenic, and then wait till their neutrophil counts probably above 1,000 before recommending vaccination. Right.
Exactly. Yeah. And there's a similar question related to platelets. I guess it's not quite as sensitive related to platelets, although low platelets would also be indicating some suppressed bone marrow function, and so we would be more cautious with that as well. Maybe have some rest period to allow some bone marrow recovery. Yes. Gosh.
Brian?
Yeah. Yes.
So one need to be also careful that, myeloma therapy that include an anti-CD38 antibodies can lower intact immunoglobulin. So although you stop the treatment, but if a patient is heavily, have a lot of myeloma being treated with these therapies, they will attenuate any immune response they have. I mean, as you know, sometimes we even give intravenous immunoglobulin to our patients because their normal intact IgG is quite low. So that's really one of the difficulty, I think, with relapse refractory patients who are heavily being treated to make sure that although we think vaccination is great, but may not be that protective.
Right, right. No, I fully agree. However, I mean, I know that in some centers they're recommending to skip, even 1 or 2 months of therapy, and I would be very, very cautious about that. So I think, again, it's just like common sense. I think that we want to avoid and be very much aware of DARA, but I would be hesitant to really delay active therapy for too long.
Yeah, I'm not saying delay active therapy. I'm just saying that the patient needs to be counseled about avoiding exposure to COVID.
Yeah, exactly. Oh, yes, absolutely. Then we have a comment back here where someone is saying that they really feel that it is important to get the antibody levels checked in some situation like a family emergency if they need to travel. It would be helpful to know what the antibody levels are, even if it's hard to interpret them. And so, yeah, so every type of situation does have a caveat to it. And so, obviously, I think the bottom line for all of this that we're talking about is that it's very, very important to discuss it with your own personal doctor, because there could be some details of your own disease or your treatment where it could be really important to see what are the antibody levels if there's a real concern about infection if you have to travel. Yeah. Let's see what we have here. Yes. Question about the optometrist. Yeah. So, I mean, I think that with the Glen Rep, with the belantamab, it does need to be teed up so that you have the eye checkups done, regularly, once a month, well, every cycle, I should say. I don't know if there's been any difficulty with that in finding, an optometrist to be able to function close by for that. Has that been something that's difficult to organize, Warren, where you have the eyes checked?
It has been a little challenging. I mean, I've tried to work with one ophthalmology group, but sometimes there's insurance issues and they may not take a particular patient's insurance. But it's important for the, not for the patient to be the one responsible for getting the eye exam. It's really the physician, hematologist who's taking care of the patient to make sure that patients have access to an ophthalmologist, prior to each dose, and an ophthalmologist who's aware of exactly the side effect of this drug, the type of keratopathy that it causes, so it can be accurately reported back to the hematologist, because there are certain dose adjustments and holding dose depending on evolving keratopathy. Right,
definitely. So this is actually interesting. So another question here relates to vaccination, but this time it's the Shingrix vaccine, and so this does raise an important point. In prioritizing vaccination right now, we've been talking almost exclusively about the COVID-19, but after transplant, obviously there is the revaccination, and then also there's just the Shingrix vaccine. So have you run into this as an issue, Warren, where you might be wanting to give not just the COVID vaccine, but maybe some other vaccines as well?
Right. I mean, we've been prioritizing getting COVID first, and then, making sure that all our myeloma patients also appropriately vaccinated against influenza, not to forget influenza, and also making sure that they've been vaccinated with Shingrix at some point. So, although priorities for COVID right now, also making sure that they've definitely been vaccinated against influenza. And Brian, I don't know if you want to touch base on this, some of the data regarding a second influenza shot for immunocompromised myeloma patients, a month after the initial
absolutely,
flu shot.
Please comment on that, the booster shot, Yeah,
it looks like, patients with influenza, again, mount a suboptimal response. And it looks like if they get two separate influenza vaccinations roughly a month apart, that they have additional protections. So I'm generally recommending that for my myeloma patients. I think there's no real downside. And if they get a little bit of additional protection, that's great.
Right, absolutely. And I mean, I think in the big picture, what we're looking at for COVID-19 is that there will be booster shots coming. And so this could be particularly important for myeloma patients. And so we are, I think, assuming that myeloma patients will not have that 100% level of antibody response. And so a booster could well also be helpful related to COVID-19. And in addition, with the new variants coming along, I think I'm certainly expecting that booster shots might become available later in the year, and they might be modified to better cover the variants that have been cropping up. And so with the new mRNA technology, it is possible to rapidly switch to have a modified vaccine. And so I don't know if you agree with that, Warren, that I'm certainly expecting that there will be booster shots for COVID-19 and probably kind of like influenza that we'll be expecting to have perhaps an annual COVID-19 vaccination.
Yes, Brian, I absolutely agree. And I think just like there's slight adjustments in the influenza vaccination every year, I think we'll have the same with COVID, where there'll be tweaks in the vaccine to cover whatever strain's most prominent at that time. So I think, yes, I agree. I think it's going to be an additional vaccination that we're going to be getting every year for the foreseeable future.
Right, absolutely. Yeah. So maybe a last question is a little bit different. A question is, with bite treatment, what is the patient experience like during bite treatment? So maybe we can broaden that to just say any of the different bispecific antibodies. And so there have been several of those in trials in the last year or so. And so have you had experience with any patients in any of the bispecific protocols, Warren? Are those open in somewhere in Florida?
I did not have them at my institution, and I think there are some at Moffitt, which is in Tampa, about 4 hours from where we are. But I have no personal experience with the bites at this point.
Okay, so perhaps we can pick that up later. I'll just comment that one of the issues, well, there's a couple of important points, which I'm sure will be discussed more later, is that the first dose of the bispecifics has to be given in the hospital because there can be this cytokine release response. So there can be a dramatic response with the first dose. Not as dramatic as with CAR T cells, but it can be important. So the first dose is typically given as an inpatient. And then with these bispecific antibodies, it's different than the CAR T, where with the bispecific, it's an ongoing therapy, which can either be intravenous or subcutaneous. And so that's another aspect. And I'm sure that's what the questioner is thinking about, is that there is some ongoing therapy, sub-Q or IV, and that there can be some ongoing impact with side effects, both systemic and with blood counts and the like. So I'll be very interested. So Paul and Rafat, you could be aware to maybe comment on that later in the day. So I think that we've covered quite a lot of different questions, a lot focused on COVID-19. So I think that perhaps we should leave it at that for this particular session and move on with the program. So So Warren, I really appreciate you taking the time to join us today. There's a comment right here, is that I guess Dr. Hoffman has had a bite trial open. So that's good for us to be aware of, that there may be some patient that's been in trials there. So thank you so much, Warren, and
thank you, Brian.
Good luck with your rounds today. And,
okay, thank you.
Well, yeah, really appreciate it. Thank you.
Okay, thank you.